The broadcast is now starting. All attendees are in listen-only mode.
Well, good evening, and welcome to another edition of Question Lab. I am your host, Jeff Downing, and tonight we are going to be working through a set of questions connected to hematology and oncology, HEMONC. So this is an area we haven't covered in a while, so we've got some good tests for you tonight. Joining me in tonight's adventure is going to be our usual guest of honor, Dr. Paris Vicaria. Paris, would you mind introducing yourself to the crowd?
Yes, absolutely, Jeff. Hey guys, my name is Paris. I currently work in dermatology. I'm also an RX coach with USMLE-Rx. So I help with sessions such as these to help you guys out. And then I'm also going to be helping with tonight's session.
Okay, so you heard from Paris. He is one of our certified RX coaches, and just kind of want to lay it out for you so that you know that the methodology that we use during Question Lab is very similar to the structure of our RX coaching sessions. So when coaches are working with students, we follow many of the same steps that we're going to be taking tonight, so that you learn an evidence-based way of answering these questions. Okay, so our main thing is whether you use our process or a version that meets your needs. The main thing is you really want to have a process that you can lean on, that you can get down pat, so that on test day you know exactly how you're going to slice and dice these questions and get to the right answer. So with that, we're going to go ahead and get started. We've got 4 questions for you tonight. We do have a raffle at the end of the session, in which one lucky attendee is going to get a subscription to RX 360 Plus. So make sure you stick around for that. Okay. So if you are new to Question Lab, you'll notice one thing that's a little bit different. There are no answer choices, and that is by design. We intentionally cover up those answer choices, and that's what we recommend that you do on test day as you're going through these. And the main reason is that it allows you to focus. Sometimes if you are looking at a question like this and you see the answer choices, if you see an answer choice that concerns a topic that you don't know very well, or maybe a bug or a drug that you can't remember, little things, especially on a high stakes examination, can throw you off your game. So we say, first thing, cover up those answer choices, and then the second step, we ask you to read the stem, which is the question part. And the main thing is that you read this so you understand what kind of information you should be looking for when we read the vignette. Okay, so we read the stem, we read that lead in, and then we read the stem. Okay, so let's start by reading that lead in. A genetic defect in the production of which of the following is the primary underlying cause of this patient's hematuria? Okay, so looking at that, now you have a better understanding of what may be happening with this patient, as well as what kind of information you're going to be looking for. So let's go ahead and read the vignette. A 30-year-old woman comes to the physician because she has had dark urine every morning for the past week. Throughout the day, her urine returns to a normal yellow color. She denies burning or pain during urination. She reports feeling more fatigued than usual lately and has had abdominal pain. Temperature is 36.6 degrees Celsius, pulse is 65, respirations are 15 a minute, and her blood pressure is 115/70. On physical examination, she appears pale and fatigued. A liver edge is palpated. Her urinalysis is unremarkable. Hemoglobin is 8.6 and mean corpuscular volume is 82. Flow cytometry shows that the red blood cells are negative for CD55-59. So again, the question, a genetic defect in the production of which of the following is the primary underlying cause of this patient's hematuria? Before I turn it over to Paris, I'm going to ask you how many steps you think it's going to take. Do you think this is a one-step question, a two-step question, three-step question? Go ahead and head to the question box and let us know what you think, and I'm going to pass it over to Paris. Paris?
Thank you, Jeff. So what we're going to do is we're going to show you what we think are the important clues in this vignette and the lead-in, okay? And so a lot of times, when you have these clinical vignettes, the first thing they're going to give you are demographics, like in this case, a 30-year-old woman, okay? So automatically, you want to make note of that because that could clue you in right away into certain conditions and what you should be thinking about, okay? Then they usually tell you, why are they coming into the hospital? Why are they seeing the doctor? In this case, it's because of dark urine every morning, okay? So that's what we call presenting signs and symptoms, and you want to make note of that, okay? Sometimes, like in this question, they'll tell you how long it's been going on for. In this case, it's been going on for the past week. So that gives you a sense of, is this more of an acute issue or more of a chronic issue? And that can also help clue you in as to what's going on, okay? Now, through this vignette, we can see that there are some other signs and symptoms this patient has, fatigue, abdominal pain, and obviously some abnormal physical exam findings that you do not want to miss. You can see there that they give us some lab findings and some flow cytometry findings. Whenever they give you a unique test like that, you want to ask yourself, why are they giving this to me? What does this mean? And then we'll kind of tie it all together with those presenting signs and symptoms, okay? And so the question is asking us about the primary underlying cause of this patient's hematuria, or blood in the urine, okay? But not just the underlying cause, but what is the defect in, is there a defect, a genetic defect in the production of something that leads to this? So I think there's a few steps here. And when we talk about steps for, these questions, we kind of ask ourselves, is this a one-step question? Like, do we just need to come up with the diagnosis here? Or do we need to figure out, the treatment for a condition, which in that case, one, we need to figure out what the condition is. And then two, what is the treatment for that condition? That's a two-step question. Sometimes they can take it a step further and say, hey, what's the mechanism of action of the treatment for the condition the patient has, okay? So in this case, I think one, we've got to figure out maybe what is the diagnosis here, okay? What's the cause of this patient's hematuria? And then two, what is the defect or problem in that condition? So I think at least a two-step question here, okay? So let's go ahead and let's take a look at those answer choices. And what we see here are 5 answer choices, okay? And when we work with students, we actually recommend that they start at the bottom, answer choice E, and work their way up to answer choice A, okay? And the reason we do this is because a lot of times we'll see students who start at the top, they'll see something they like, and they'll select it without going through all the answer choices. So sometimes, as a result, they'll get that question wrong. So we recommend doing it this way to prevent yourself from making this mistake. So we'll go ahead and we'll do that now. Answer choice E, proteins that interact with the RBC membrane skeleton. D, mitochondrial metabolic enzyme. C, membrane-bound complement inhibitors. B, component of the hemoglobin synthesis pathway. And A, cell surface anchoring molecule. So we'll go ahead and open up that poll. Go ahead and select what you think is the best answer here, and we'll talk about it in just a few seconds.
Excellent. Thank you, Paris. So the poll is open. Go ahead and take your best shot. What do you think is the primary underlying cause here? What is the genetic defect? A lot to parse here, and this is important. With especially hem-onc, a lot of these questions can be a additionally challenging, sometimes some of the harder questions that you see there on step 1. And there's a lot of things that you're needing to get straight in your head. So this is a good way to start it off tonight. Let's see, we've got, looks like about 3/4 of you have voted. So let's go ahead and I'm going to close the poll. Interesting here. So looks like we got 2 leading answers. So 34% of you thought cell surface anchoring molecule. It's where that defect may be coming from. Membrane-bound complement inhibitors coming in second, and proteins that interact with the red blood cell membrane skeleton. Well, distant third, but we're receiving about 14%. So let's go ahead and hide those results and reveal the answer. And the answer is answer choice A, cell surface anchoring molecule. So that was the leading answer answer getters. So we'll call that a win. About 2/3 of you though didn't hit it. So let's walk through it. Pars.
Yes, thank you, Jeff. Yes, great job on this first question. So let's talk about what's going on here, okay? So you can see here right away they told us that she's waking up with dark urine every morning, okay? So that should really make you think about a nocturnal issue of hemoglobin in the urine, or a condition known as paroxysmal nocturnal hemoglobinuria, okay? Usually dark urine in the morning that then resolves in the daytime. They said that throughout the day, her urine returns to a normal yellow color. So another important clue there, okay? We also know that her flow cytometry was negative for CD55-59. We'll talk about what that means. That means her RBCs don't have that, okay? So if we take a look at the next slide, looking at our first aid table on this condition, this condition results from a mutation in PIGA, and these help produce anchors, okay? These anchors attach to the extracellular surface of cells, okay? As you can see, there are 2 of those proteins are CD55 and CD59. These prevent or protect the red blood cell from being destroyed by complement and the complement pathway. Because they don't have this, they are susceptible to attack by the membrane attack complex of complement, and thus hemolysis, and their RBCs break down, okay? As you can see there on the right side, that right column usually presents with dark urine in the morning, and on laboratory finding, RBCs would not have CD55-59 on flow cytometry, okay? You can also see there another section on PNH in first aid that kind of goes a little bit more in depth on that as well, okay? So if we go back to our question, hopefully you guys can see how answer choice A is the best answer. We do not have those anchoring molecules on the cell surface, okay? Now the other answer choices, if you picked that, so answer choice E is getting at hereditary spherocytosis, which is a little bit different. Patients would present with splenomegaly, jaundice, things like that. Answer choice D is a little bit of a kind of distractor there, not too much with what's going on here. The second most commonly selected answer was answer choice C, and that's getting at kind of trying to distract you a little bit. The cell surface anchoring molecules protect you from complement attack in this condition, but they are not inhibitors per se of complement. They're not specifically membrane-bound complement inhibitors, okay? So kind of a little bit of a distractor trying to trick you there. And then answer choice B, that's getting more at something like thalassemia, which is a more of an anemic condition. So great job on this first question.
Yes, definitely. Nice work, everyone. Way to get started. Hopefully everyone is warmed up and we're ready to hit question number 2. Before we do that, I want to remind you that we do have a free podcast called the RX Bricks Podcast. If you are one who likes to study on the go and make the most of your study time, this is a great way to do it. Whether you're washing dishes, walking in the park, head to the gym, or even in your car, we release a new podcast episode every week that reflects one of our bricks. So we've got right now I think close to 150 episodes to choose from, and all of these episodes usually about 15-20 minutes, so easy to consume, and it'll really help you reinforce some of the key foundational material that we cover within the bricks. So if you haven't checked it out, make sure you do that. The RX Bricks Podcast. Okay, question number 2. Again, we've got those answer choices covered up, and we're going to start again with the lead-in. Which of the following complications is most associated with this patient's most likely disease? Okay, there's quite a few conditions jammed into that question. So let's read the vignette. A 64-year-old male comes to his physician because of a 3-month history of lethargy and cough with brownish sputum. He has been treated twice in the past 3 months for community-acquired pneumonia. Temperature is 39.1. Physical examination is significant for right-sided pulmonary crackles, non-tender cervical and axillary lymphadenopathy, and hepatosplenomegaly. Laboratory studies show the following: leukocyte count 40,000, neutrophils 20%, lymphocytes 77%, eosinophils 1%, monocytes 1.5%, basophils 0.5%, hemoglobin 8.2, platelet count 190,000. An image of his blood smear is shown here. So, taking all that in, the question is, which of the following complications is most associated with this patient's most likely disease? Let us know how many steps you think it will take to answer this question. Let us know down there in the question box as I pass it off to Paras.
Thank you, Jeff. So what we're going to do is now show you in this question what we think are the important clues in this vignette and a lead-in. Okay, so now we've got a little bit of an older patient, a 64-year-old male, okay? And we know that he has lethargy and a brown sputum cough, okay? So not good signs and symptoms, okay? We also know it's been a little bit chronic, right? 3 months going on, okay? So you want to make note of that. Now we know also that he's been treated twice in the past 3 months for community-acquired pneumonia, okay? So you want to ask yourself, why are they telling me that? Why are they telling me that he's been treated twice for that condition, okay? So, they then give us very important vital signs, physical exam findings, okay? And then, as is going to be the case with hematology-oncology questions, you are often going to get a lot of laboratory studies, okay? White blood cell counts, red blood cell counts, and not just that, but the differential breakdown, so the type of white blood cell count as well, okay? And on top of that, even more in depth sometimes on the type of immature cells as well. So early blast cells, things like that, myelocytes as well. So you definitely want to make sure you're looking at those normal range of values, figuring out, hey, what's abnormal here, what's abnormal. Sometimes it is helpful to know some of those common ones and normal ranges for that, like hemoglobin, leukocytes, platelets, things like that. And then, as you can see here, they do give us a blood smear as well. You definitely are going to have to interpret a lot of blood smears going forward. So they ask us about a complication associated with this disease that the patient has, okay? So I think we've got a couple steps here. I think one, we've got to know or come up with the disease that this patient most likely has. And then two, the complication most associated with the patient's most likely disease. So a two-step question here, okay? So let's go ahead and let's take a look at the next slide. We'll kind of blow up that smear for you so you guys can take a good look at what's going on, okay? And after this question, we'll kind of talk a little bit about some of the pearls for looking at smears and how you can quickly identify things and things like that. All right, and we'll move on to the next slide, and don't worry, that smear will still be there in the bottom right of that slide. And we'll take a look at those answer choices now. Okay, so once again, starting at the bottom and working our way up to the top. Answer choice E, progression to blast crisis. D, lytic bone lesions. C, disseminated intravascular coagulation. B, autoinfarction of the spleen. And A, autoimmune hemolytic anemia. So once again, we're going to go ahead and open up that poll. Go ahead and select what you think is the best answer here, and we'll talk about it in just a few seconds.
Fantastic. Thank you, Paris. So choose your complication. Which one do you think is most associated with this patient's most likely disease? And you've got to answer a couple of questions before you can answer the real question, right? So hopefully you're able to parse all of that that lab data and got a good look at that smear. Again, on test day, you don't have a ton of time, right? You've got what, roughly 90 seconds per item. So having an approach, following your your methodology, it's going to be really, really important to make sure that you are as efficient as you're going to need to be on test day. Let's see, about half of you have voted. I do want to remind you, on test day, you never want to leave a question unanswered. It's not going to count against you. And we definitely want to make sure that you're answering all the questions here during Question Lab. Okay, about 3/4 of you have voted, so let's go ahead and close the poll. And, well, I don't think that there is a clear favorite here. Autoinfarction of the spleen received the most votes, but this looks like a fairly even split. Even the lowest vote getter is only 10% off of the highest vote getter. So clearly, I think we've got some confusion, a little bit of a challenge with this one. So let's go ahead and hide the results and reveal the answer. And the answer to question 2 tonight is answer choice A, autoimmune hemolytic anemia. That was tied for 4th in terms of vote getters in this question. So looks like we've got a little bit of work to do. Paris is going to walk us through it. Paris?
Yes, thank you, Jeff. Definitely a tough question. Okay, so let's take a look at what's going on. Okay, so this is an elderly gentleman. Okay, like I said, those demographics are oftentimes very important. Okay, there's some conditions where, even if you don't necessarily know what's going on, if you know if it's young male, old female, kind of make an educated guess. Okay, so this is an elderly patient with frequent infections. Okay, has had a few pneumonias. We already know he's been treated twice, and now maybe getting another pneumonia. He's febrile. He's got some pulmonary crackles, brown sputum, so another infection. He also has an enlarged liver and spleen, hepatosplenomegaly. Okay. On top of that, the white blood cell count does not look good. Got a lot of white blood cell counts, very high. Okay. And if we take a look at that smear in the bottom right, you can see I count about maybe 5 of what we call smudge cells. Okay. Those little white blood cells that look like they were kind of pushed and pushed and pushed, and they kind of grew outward a little bit, what we call smudge cells. Those are neoplastic lymphocytes that become damaged when the slide gets prepared in the technique that we use. Okay, so that's why they are called, and that's why they kind of look smudged. Okay, and these are kind of characteristic of CLL, chronic lymphocytic leukemia. Okay, so let's take a look at the next slide. We'll take a look at our leukemias. Okay, and we can see here CLL. The first thing they tell us, age greater than 60. So right off the bat, that very first clue they gave us of a 64-year-old male, was actually very helpful. Okay. We can also see there in red text, CLL, crushed little lymphocytes or smudge cells. Okay. Right before that, you can see it is associated with autoimmune hemolytic anemia, okay, which was the correct answer here. And actually, on the next slide, there's another section in first aid on hemolytic anemias, specifically autoimmune hemolytic anemias, and what infections, what drugs, what conditions are associated with that. And you can see there that CLL is associated with autoimmune hemolytic anemia. Okay, so definitely an important association to know. So we'll go back to our question and our other answer choices. Take a look if you selected that. So answer choice E, progression to blast crisis. That is getting more about CML, chronic myeloid leukemia. Okay, a little bit different. Answer choice D, lytic bone lesions. That's more common with multiple myeloma. And usually you see the rouleau formation of a lot of red blood cells that are kind of sticking together. Answer choice C, DIC, that's getting at a different condition. We'll talk more about that. And then answer choice B, autoinfarction of the spleen, usually more common in sickle cell. Okay, so when you're evaluating these smears, you want to make sure that you know what are your normal components of a smear. So red blood cells, white blood cells, and platelets. And you want to see, are there any abnormalities that jump off right away to you? And right away, I see those kind of weird tissue paper-like cells on the smear, and that's what jumps out at me. The RBCs look okay. Generally, they're going to give you a smear that kind of highlights the abnormality. So if you're questioning, well, is this really a spherocyte? Is that really, central pallor of an RBC? You might be looking too much in depth. So you definitely want to see, what's the first abnormality that comes out to you. And also to know the ratios. You should have a lot of RBCs in your slide. You should have, lymphocytes and other white blood cells kind of peppering the slide, and a couple platelets here and there. And remember, platelets are supposed to be very small. So if they're very big, also an abnormality. So important to know your size, your proportions, and what's the first thing that kind of jumps out to you. Okay, so another helpful clue there for your hematology slides.
Excellent. Thank you, Paris. So good work, folks. That was a tough one, but hopefully you're gaining a lot of knowledge as we work through these questions. We're going to get to question number 3 here in a minute, but if you are starting to think about step 1, or you've got step 1 on the horizon, we have a free study planner we call the RX Study Planner, and it is designed to help you put together your study plan for both for step 1 or for step 2. So this is we recently expanded it so that if you're getting ready for step 2, you can also use this. It's correlated with first aid. And the nice thing is that you can make determinations about what you want to study, and then also how well you know the material, so that you can, if you're having issues with Hem-Onc, you can put, place more emphasis on that, and place less emphasis on a topic that you know like the back of your hand. So it's easy to use, it's free, and it's a good way to help you, structure your long-term study plan. Maybe you think you need 6 weeks or 8 weeks for step 1. Maybe you need longer. Maybe you feel like you need 6 months. You can adjust the plan accordingly. So we've put the link here in the chat. So definitely check it out. Okay, so let's go and hit question number 3. Again, we've covered up all of the answer choices. We've got another image for you. And we're going to start off again with the lead-in. Which of the following is most likely to be associated with this patient's likely condition? Okay, a couple of likelies there jammed in the question, so I'm going to have to do a little clinical reasoning here. So let us read the vignette. A 63-year-old woman comes to the office because of worsening fatigue for the past 2 weeks. She has also started noticing bruising on her skin and lips. The patient appears pale on physical examination. No enlarged lymph nodes are present, nor is there hepatosplenomegaly. Non-blanchable petechia are present on the lower limbs. A complete blood count reveals the following. And you can read the CBC right there. And again, the patient's peripheral blood smear is shown. Okay, taking all of that in, let's read that lead in again. Which of the following is most likely to be associated with this patient's likely condition? Think about how many steps it will take to solve this one. Let us know in the question box as I pass it off to Pars. Pars?
Thank you, Jeff. So let's take a look at this question now, okay? So we've got an elderly female, a 63-year-old woman, okay? And she's got worsening fatigue, and they tell us how long, past 2 weeks. So those are our important clues that we've highlighted there, okay? Now we can also see there's some issues with bruising, okay? Very important that that's like, one of the first few things they tell us right off the bat, okay? She's pale, there's petechiae. They also are very astute in telling us there's no enlarged lymph nodes. There's also no hepatosplenomegaly. So we want to make note of that because we can see those in certain conditions. We can see that absent in certain conditions, and we want to make note of that. Okay. As mentioned, it's going to be very important to come up and be able to interpret these lab values. Okay. Is that hemoglobin low? Is it not? How are those platelets? What about the remaining cells? You can see they give us a lot of immature cells here as well. Myeloblasts, promyelocytes, myelocytes, things like that. Mature myelocytes, okay? So how do we interpret that, okay? Obviously we want to make note of it, and we'll kind of talk about that, but you definitely want to highlight those and because those are going to be important to coming up to this question. You can see here another blood smear is shown, okay? They're asking us, again, what's most likely associated with this patient's likely condition. So one, we've got to figure out what is this patient's condition, and then two, what may be associated with that condition. So I think another two-step question here. So let's go ahead and let's take a look at those answer choices. And once again, starting at the bottom. Answer choice, actually, sorry, we'll go back to that slide. Let you guys take a blown up look at that smear, okay? And again, I'll give you some pearls for interpreting smears like this as well. Don't worry, we'll move on to the answer choices. We'll leave that still there in the bottom right for you to take a look at. Answer choice E, microangiopathic hemolytic anemia. D, increased leukocyte alkaline phosphatase. C, greater than 20 lymphoblasts in bone marrow. B, decreased plasma von Willebrand factor activity. And A, blastic bone lesions. So we're going to go ahead and open up that poll. Go ahead and select what you think is the best answer here, and we'll talk about it in just a few seconds.
Yes, indeed. Here we are. We've got all of the answer choices up. Out of all of these options, which do you think is most likely associated with this patient's likely condition? Let's see. About a third of you have voted, and again, no clear favorite so far. So looks like we've got another challenging one here. As a reminder, we will have a raffle at the end of tonight's webinar. Also got a really interesting webinar set for next week I'll tell you about. So hang in there. Okay, let's see. Almost 2/3 of you voted. I'll give you a few more seconds, and then we're going to close the poll. If you don't know it, just go ahead and take your best shot. Okay, we're going to close the poll and share the results. So again, we've got about 3 of these answers that received a lot of the votes, with greater than 20% lymphoblasts in bone marrow being the leading vote getter. But microangiopathic hemolytic anemia and increased leukocyte alkaline phosphatase being right on its heels. So let's go ahead and going to hide the results and reveal the answer. And the answer is answer choice E, microangiopathic hemolytic anemia. So again, that came in second amongst all of the options. So again, if you didn't get it right, that's okay. The main thing to think about is we want to get it right on test day, and Paris is going to help us with that right now. Paris.
Thank you, Jeff. Yes, definitely. Let's take a look at this. Also, a very high yield diagnosis here. Okay. So this patient likely has AML, acute myelogenous leukemia, and a specific subtype, APML, promyelocytic leukemia. Okay. This patient has anemia, thrombocytopenia, leukopenia. They've got pancytopenia, all the penias. Okay. And we're also given abnormal cells as well, mature myelocytes. Okay. So more than likely, this is going to be a myeloid neoplasm, not a lymphoid, but a myeloid. Okay, that's a very important distinction that could automatically, cut off half the diagnoses. You need to think about if you can tell, is this myeloid or lymphoid? We see the myeloblasts are elevated, the myelocytes are elevated, so most likely myeloid neoplasm. Okay. We can also see there that the promyelocytes are 10%, which is high. And that's what you can see in APML, acute promyelocytic leukemia. Okay. So if we take a look at the next slide, we will take a look at our AML. Okay. Once again, median age of 64. Our lady was 63-year-old female. Okay. And this is a myeloid stem cell proliferation. So you're going to have a lot of myeloid cells being produced. Okay. And this is actually CML. But we'll take a look at the next slide. Sorry about that. This is actually AML that this patient has. But we can see here that this is microangiopathic hemolytic anemia. Okay, this is when RBCs are damaged, and you can see those in conditions such as DIC. Okay, now one of the important things about APML, if you remember, is APML can lead to DIC. Okay, and thus, as a result, in the setting of DIC, you can see microangiopathic hemolytic anemia. So it was kind of an extra step here. What's associated with AML? Well, DIC is associated with AML. What is associated with DIC? Actually, microangiopathic hemolytic anemia. Okay, so if we go back to our question and we take a look at that smear, let's evaluate that. Hopefully, on that slide, you can kind of see that they have put in that triangle that one cell that's very important. You can kind of see those those purple filamentous rods. Those are called our rods. And you see that specifically in AML. Okay. One of the key things that can help you figure out if this is a myeloid neoplasm or a lymphoid is when you look at those cells, do you see a lot of granules? Okay, and we do. We can see in a lot of those cells a lot of purple dots. Those are granules. And granulocytes are part of the myeloid line. Okay, so if I had to take a guess, I didn't know anything about this question, just by looking at that slide, and I see a lot of granules, I'm going to think this is more of a myeloid neoplasm than a lymphoid neoplasm. If, on the contrary, I see a lot of cells where there's not a lot of cytoplasm, okay, the nucleus is taking up the majority of the cell, even in leukemias, that is more of a lymphoid neoplasm. So just by looking at the cells, not knowing anything about the question, you can automatically get a clue as to, is this more of a myeloid or a lymphoid neoplasm? And boom, you've already cut in half your diagnosis by half, okay? So the other answer choices here, let's talk about those. Answer choice D, increased leukocyte alkaline phosphatase. That's usually seen more in stress, infection, polycythemia vera. Answer choice C, which I believe was the most highly selected answer, that's more common in ALL. Again, you can see that's talking about lymphoblasts, not myeloblasts, okay? Answer choice B, that is more consistent with a bleeding disorder, which is not what we have. We have more of a leukemia here. And then blastic bone lesions, again, a lot of different cancers like prostate cancer, breast cancer, not what we're getting at here. So definitely another tough question here.
Okay, thank you, Paras. So it's been a good session so far. I hope you guys have learned a lot. We're gonna get to our final question here. Again, we're gonna do a raffle at the end of the evening. So stay close, and let's go ahead and work through our last question of our Hem-Onc question lab. Again, we've got all of the answer choices covered up, and we're going to start with the lead-in. This patient's excessive bleeding is most likely to be associated with which set of laboratory results? So we do give you a little bit of a sneak peek here at what the answer choices are, but you're going to need to home in on the vignette first. So let's read that. A 63-year-old male comes to the emergency department 4 hours after a fall with ongoing bleeding inside his mouth that started when he fell. He has chronic kidney disease due to type 2 diabetes. He has no family history of bleeding disorders. Temperature is 37.5, pulse is 103 and regular, respirations are 16, and blood pressure is 150/90. Physical examination shows bleeding from his cheeks and gums and ecchymosis over his extremities. Laboratory studies are as follows. You can look at all of the labs there. Give you a second to read through it. Okay. So again, the question, this patient's excessive bleeding is most likely to be associated with which set of laboratory results? And we've got the table that we'll be working through as I pass it off to Paras. Let us know how many steps you think this question is going to require in order to solve it. Paras?
Thank you, Jeff. So now, this is our 4th time doing this. So hopefully you guys are starting to get a sense of what are those, clues in these Hem-Onc questions that you need to be picking up on. Demographics, lab values, things like that, okay? So again, we've got an elderly patient here, a 63-year-old male, who's had bleeding inside of his mouth, okay? It started 4 hours ago. They tell us about past medical history, CKD and diabetes, nothing in the family. You definitely want to know if there's any family history of bleeding disorders in case this is something genetic. Again, physical exam findings. And again, as I highlighted, very important to look at those lab findings and figure out, what's relevant here, what's abnormal, okay? Now this question is asking us about the excessive bleeding and what is it associated with in terms of lab results? And I think we've got to figure out maybe what is the condition or diagnosis here? And then 2, in that condition, what would we see with those different lab values? Prothrombin time, APTT, activated partial thromboplastin time, and platelet count, okay? So we will go ahead, we'll take a look at those answer choices. You can kind of see them right there. And so we'll start at the bottom. Answer choice E is saying that your PT is normal, your APTT is increased, your platelet count is decreased. Answer choice D is saying your PT is normal, your APTT is increased, and your platelet count is normal. C is saying everything is normal. B is your PT and APTT are increased, but your platelet count is decreased. And then A is saying your PT and APTT are normal, but your platelet count is decreased. Okay, so we'll go ahead, let you guys take another look at that vignette as well. And then keep this here, let you guys kind of look at that for a few more seconds, and then we'll open up the poll after that.
Okay, everybody. So again, once we launch the poll, you're only going to see the answer choices. You won't see the different columns. So go ahead and figure out which one you think is indicative of this patient's situation. Okay, we're going to go ahead and launch the poll. Again, this patient's excessive bleeding is most likely to be associated with which set of those laboratory results. So pick your letter, and we're going to launch the poll. So it should be a quick one. Go ahead and let us know. Again, we always remind you that there's no penalty for guessing on test day. You don't want to leave any step 1 questions unanswered. You have to, kind of keep an eye on the clock, but don't let that block run out with all of those without at least giving each question a shot. Okay, let's. We got 3/4 of you have voted, so let's close the poll. And well, I think that this has been a bit of a theme tonight. No clear favorites. There was a tie for first place between C and D, which is both of them were associated with normal except the increased in activate partial thromboplastin time with D. So, okay, let's go ahead and we'll hide the results and reveal the answer. And the answer is answer choice C. So again, that's the tied for the leading vote getter. So nice work on that one. 28% of you got that one right. If you didn't get it right, that's okay. We're going to walk through it with Pars. Pars.
Thanks, Jeff. Yes, definitely another tough question, but one that's very important and which you will probably see in your clinical experience, okay? So this patient is having, as we are told, some issues with bleeding, right? Ongoing bleeding. But we know there's no family history of bleeding disorders, okay? We see there that the hematocrit is normal. The white blood cell count is normal as well, okay? What really stands out is that BUN and creatinine, very high, right? A super high creatinine and super high BUN. We know this patient has CKD. And so what you can have, and we'll move on to the next slide, is an issue where you have too much uremia or uremic platelet dysfunction. So that uremic toxins in patients with renal failure, those uremic toxins accumulate and they don't allow your platelets to work normally. They can't form that platelet plug. They can't adhere to another to stop that bleeding, okay? So if you ever have a traumatic site of bleeding, or if you ever do like an IV line in a patient with this, you'll notice it's very hard to stop that bleeding, okay? And basically the way to control this is to get their kidney function under better control. This is one of the indications for dialysis, okay? Really high BUN. You can see there that the bleeding time is going to be elevated, but obviously your platelet count is normal. We're not destroying platelets here. They're just not able to work well together, okay? So if we take a look at the last slide, the previous slide, we'll take a look now how answer choice C makes the most sense. normal PT, PTTT, and platelet count, because everything's normal in terms of lab values. It's more so just the kidney function is preventing the platelets from working well. Okay. The other answer choices are all getting at some sort of bleeding disorder or other condition, which is not what we have going on here. Okay. So answer choice E is getting at, a chronic DIC where your platelet count is low. Answer choice D is getting at hemophilia, which is again a genetic condition, and you would see in childhood. Answer choice B is getting at DIC as well. And answer choice A is getting at a condition such as ITP, where you lose your platelets, they're getting destroyed. Again, not what's going on here. So definitely some tough HEMOC questions today. Hopefully you guys learned something about analyzing these, analyzing smears as well. And I will pass it back to you, Jeff.
Excellent. Thank you, Paris. Again, this was a good, challenging set of questions tonight. And regardless of whether, you got all of the answers right or you got all the answers wrong, the main thing is hopefully you're taking away, a lot of good nuggets regarding the actual content, but also ways in which you can break these questions down effectively on test day. So well done. Just so glad that we had all of you here tonight to work through them. Now, if you want to take another look at these questions, I've got all of the QIDs here. If you go to the RX search area within USMLE-Rx, and you can drop the QID numbers in there, and it will provide more information regarding the whether it's the explanations as well as the all of the incorrect rationales. So go ahead and screenshot that if you want to, or write them down, and you can continue studying.